So many of you liked the review of the first episode of The Pitt, and I love teaching, I love talking about healthcare, so let's get right into it, episode 2. Huge thanks to Grammarly for sponsoring this video.
Nick Bradley, 19, found unresponsive by parents.
I love that this just continues. It feels like I'm on the shift. When I said this was too real, I meant it.
On arrival, he was barely breathing with pinpoint pupils.
Pupils responded to Narcan, but we tubed him when his respirations didn't pick up.
So when someone has pinpoint pupils, you worry about an opioid overdose. It's one of the side effects of taking opioid medications. And these days, we're doing a better job at making sure Narcan is widely available. Narcan is an opioid reversal agent. It's usually done in the form of a nasal spray. Now, in some states, you're able to buy it over the counter to store in your home because there's overdoses happening everywhere.
Heart rate 64, BP is cycling.
No response to pain, GCS3.
GCS3 means you're intubating the patient because anything below 8, you intubate. I'm gonna keep hammering that home. Oh, he's already intubated, that's good. I don't know if he came in intubated, I may have missed that.
If it was just opiates with Narcan, he'd be breathing on his own.
He's experiencing sedation, heavy sedation, likely not related to opioids given that Narcan didn't do anything. There could be other toxic substances that can cause symptoms like this.
Beta blockers shouldn't give pinpoint pupils.
Maybe parents had some prescription meds in their bathroom.
They're on their way.
And beta blockers are generally not something people overdose on. I mean, obviously it could happen, and there are medications we could use to reverse beta blocker overdose.
No blood in the belly, no pericardial effusion.
So that means that they're ruling out any kind of pericarditis, cardiac tamponade, obviously no abdominal bleeding, which is very important because you could bleed a lot into the posterior abdominal cavity where you have a lot of blood being lost and not realizing you're losing it. Although the heart rate would usually point to that happening by having tachycardia with low blood pressure.
And lungs are up.
So no pneumothorax, meaning the lungs have not collapsed.
BP 84 over 58.
84 or 58 means he's hypotensive. Could be infectious etiology, but I would like to see his heart rate respond. Basically, the reason I want his heart rate to respond is there's a compensatory mechanism that when you become hypovolemic, meaning that your blood pressure is low from low fluid, either from bleeding out or septic shock, some form of shock, your body naturally tries to compensate by creating your heart rate to go faster and increase cardiac output. So the fact that his heart rate is low and blood pressure is low means he's either very, very much in shock from something serious or his heart rate's not compensating because there's some toxicity on board.
Push dose epi, 0.1 milligram, Foley for urine, stabilized for CT, and throw a wide net.
I'm curious, they're giving epi, so they're giving pressor to increase blood pressure. I'm surprised that they're not giving him wide open fluids to see if he's fluid responsive.
Systolic back down to 90.
Another 0.1 of epi.
Flaccid paralysis of all 4 extremities.
What can cause flaccid paralysis? I know in babies, you could have botulinum toxicity, Clostridium botulinum. Wow, I don't know.
No eye movement with ice water.
So no brainstem function.
Due to?
Hypoxic injury, massive hemorrhage. Samara, escort him to CT.
They thinking he has a stroke?
The son and daughter of Mr. Spencer from assisted living, they're here.
Your father has pneumonia and a condition called sepsis.
So when someone has pneumonia, there's a bacteria present in the lungs, and that bacteria oftentimes can seed into the blood and then spread throughout the body. And what that bacteria can do is create toxins that can lead someone to go into sepsis, septic shock, which means that their blood vessels dilate, they get massive drop in blood pressure, and if that blood pressure and that bacteria are not adequately treated, meaning that we have real protocols that we use called sepsis protocols, by putting on antibiotics, fluid resuscitation, by giving massive fluids to raise that blood pressure, because without that blood pressure, you're not perfusing vital organs like the brain, liver, kidneys, and you could lose your life simply because people didn't act fast enough. So that's why we try to do a good job at quickly identifying those who have infectious potential sepsis etiology and treat them as quick as possible. Hospitals are actually judged on this based on their response time to the sepsis protocol.
Hey, Pop. It's Helen and Jeremy.
Jeremy. Hillary. Boob.
Bud. It's the nowhere man from Yellow Submarine. It's what he used to call me when I didn't do my homework.
Is this his baseline?
He has good days and bad days.
This is the most important question a good doctor will ask. Altered mental status, AMS for short, is hard to judge when you're meeting someone for the first time. For me as a primary care doctor, because I have a continuity with my patient, if I see them in the emergency room or the outpatient setting, I can tell if they're altered. I can tell if they're acting differently, that something's not right. But when you're an ER doctor, you're meeting someone, especially of old age, you don't know if this is the baseline for them and this is how they act normally, even when they're healthy, or is this them acting in an altered mental state because there's a stroke happening, there's worsening sepsis, and that's why a family being at the bedside increases the possibility for better healthcare communication. Obviously, there are extreme examples of the family's combative or there's arguments amongst the family that it could be more drama, but in general, it's good to have a healthcare advocate.
Why don't we step out for one more second?
In a situation like this, it's good to talk about end-of-life care. What should be done if a person's heart were to stop? This is happening here during an acute case of sepsis, which obviously very, very important to talk about, especially someone who's of old age and not living the greatest quality of life, because clearly there's some dementia involved. It's equally as important to have that same conversation with people who are young entering the hospital or going in for their preventive visits, because you always want to make those decisions when you're of right mind, or at least put someone in charge as a healthcare proxy, power of attorney, to make those decisions for you if you're incapable, because you're sedated, because you have a bad injury, etc.
Your dad has an advanced directive expressing his wishes, which says that IV fluids and medications are okay, but no artificial life support, no CPR.
I mean, he doesn't want a bunch of machines keeping him alive.
Okay. Then we will continue with oxygen and IV fluids and antibiotics. But if his lungs stop working, we're not going to place a tube in his windpipe for a breathing machine.
But pneumonia is treatable.
Most of the time it is.
The right way to talk about this, and he's doing a great job, I'm not critiquing him by any means, is explaining that while a condition might be treatable, when someone comes in of old age, frail, already living a worse quality of life than they want to, and then they get a bacterial infection on top of it, that's a huge stress on their body. And how they respond to that is up in the air. Once their heart stops and they need CPR, they need a breathing tube, the chance of bringing them back is already quite low. That's number one. Bringing them back brings so much stress onto their body that their new baseline, even in the best case scenario, is going to be significantly worse than when he came in if everything goes according to plan. So while pneumonia is treatable, while we can bring people back from CPR, it's not always advisable, and that's why patients make an advanced directive like this gentleman did.
But if he can get better in a week, then put him on a machine.
That's not what he wanted.
Do either of you have durable power of attorney for healthcare?
Yes.
We both do.
Okay. Well, this is a decision that does not need to be made right now. Why don't you think about it? Talk about it. If things get worse, sometimes allowing for a comfortable natural death can be the most humane path.
Very true, and talking about it very honestly, matter of fact, is very good.
So, how's the VA?
Yeah, it was good. Challenging. I learned a ton.
How'd you choose the Pitt?
Oh, I have a sister with special needs, and she got into this really great facility here in Pittsburgh. And PTMC has such a great reputation. I thought, it'd be a good.
Can I present my headache to you?
Yeah. What do you got?
This is exactly how it happens when doctors meet younger interns, residents, etc. They learn something about them, like one thing, like the instrument they play, where they did their previous medical school education, and they just focus on that. And it's not because they don't care. It's because the facility's so busy, but you want to create some rapport, so you find it on one specific point of curiosity, of relatability, all of that.
A 36-year-old woman with severe headache due to paracervical trigger point. Her pain went from 11 to 0 after 2 cc's of IM Marcaine.
Wait. You did a trigger point injection before presenting the case?
Yeah.
Interns always present first.
Someone coming in with a headache immediately to go in with a trigger point injection in the ER is very aggressive, and even more aggressive for an intern to do it without speaking to an attending first. So this definitely breaks protocol, because there's a whole host of things that need to be ruled out that are life or death before you start just giving someone numbing medication as a form of trigger point injection.
I spent a month at the pain clinic.
It's not okay.
I'm very comfortable.
It's definitely not okay.
23-year-old Ben Kemper, no helmet, got doored riding an e-scooter. Neck versus handlebar, then face planted to the pavement. Obvious facial fractures, but alert and oriented with good vitals.
How we doing, Ben?
One. Back in my throat.
That's probably from the nosebleed. Short, rapid rhino, please.
That's the rhino rocket that you may have heard me mention in the past on the channel, where they inflate basically a giant inflatable tampon-esque device inside the nose to prevent blood going from the fractured nose into the back of the throat. Very uncomfortable, not good for the digestive system, and can lead to choking.
I'm gonna stick something in your nose to stop the bleeding.
No hemotympanum.
That means no blood in the eardrum, which could be a sign of a basilar skull fracture.
What's up?
Good vitals, A&O.
A&O means alert and oriented. Ideally, you want to do A&O times 3, which means alert and oriented to time, person, and place. So do you know what day it is? Do you know where you are? Do you know who you are? And sometimes people throw in a fact like who's the president or something. Oh, that's a zygomatic arch fracture if I've ever seen one.
Floating face.
The 4-3 fracture.
You don't see that every day.
Actually, maybe that's not even a zygomatic arch. Maybe that's like the sphenoid. I don't even know what's broken there.
Ketamine and sucks on board.
Pulse ox holding at 94.
So they're sedating him?
Just in case.
Let's have a look.
Lots of swelling. I can't see the cords.
To the right.
We're down to 85.
All right, pull out eye gel, bag and crack.
They're trying to figure out if they can put in a breathing tube through the mouth, but there's a lot of edema, aka swelling, because of the serious nature of the trauma. So they're talking about cutting in directly into his windpipe, into the area right here.
You've done this?
Yes, in the cadaver lab.
Let's hope that's not where this poor soul ends up. We'll do an open technique since we have a minute.
Okay. Okay, you're gonna be making a vertical incision to avoid the jugulars and the carotids.
Very important why they do a vertical incision here. There's 2 very important blood vessels that run side by side. So if you were to make an incision like this, very possible to cut those, massive bleeding, potential death. So you want to be very careful and do the incision vertically there.
Get ready to bag the crack.
Oh, excuse me. No worries. End tidal CO2 is yellow.
Yellow is yes, nicely done, sew it in.
Sometimes if you don't put it in the right area, which here it's a much lower chance that could happen, but when you're putting in a breathing tube, it is possible to put it into the wrong hole, literally. And as a result, when you pump, if you don't have carbon dioxide coming out, you suspect that you inserted it into the wrong hole and you reinsert. We do chest x-ray to confirm placement though. Back to the Pitt in just a second, but first I want to tell you about Grammarly, an AI writing partner that works seamlessly with your everyday apps and helps professionals write better and faster. I've been working on a script for an upcoming animated video about smallpox, and believe me, this thing is a beast. With the help of Grammarly's AI writing tools, I've really tightened things up and it's becoming much more manageable as a project. One feature I love is called Quick Fix that actually comes with the free version of Grammarly. It polishes my writing as I go, helping me stay in the flow. With the press of a single button, I can accept the suggestions all at once. Game changer. They have pro features too, like strategic suggestions. You see, once I finish writing a section, I can ask Grammarly to give it a review and suggest ways to make it better. A lot of the smallpox video is pretty medically dense, but I want the story to be dramatic too, so with strategic suggestions, Grammarly helps me find that balance, all while keeping my own voice at the forefront. 96% of Grammarly users report that Grammarly helps them craft more impactful writing, so sign up for Grammarly free and upgrade to Pro if you want to take productivity to the next level. All right, let's get back to the Pitt.
Thanks. Just received word your son's head CT is normal and he's maintaining a good heart rate.
You got him
good
back.
blood pressure.
Thank you, thank God.
Right now he's unconscious with a tube in his throat for oxygen. Why don't we step out for a minute while they get him settled, and then you can come back. You can sit with him as long as you want.
Something's gonna happen.
Nikki, it's Mama. I'm here, babe.
You're doing great, son.
Blown.
A blown pupil on one side could mean bleeding in the brain, but they just did that.
So, we don't know how long he was at home without breathing.
He's breathing now?
Not on his own.
But he's gonna wake up.
We certainly hope so. We're gonna know better after we get some more test results back.
Really, when we know more, is less so about test results when it comes to neurologic injury, but more so when we see improvements. So a lot of times it's a watch and wait approach, which is terrible for families because you don't have a good prognosis to give them. And that happens very commonly with strokes, with head traumas, and hypoxic injuries like what happened here, where his heart wasn't beating strong enough to perfuse the brain. As a result, there was some kind of injury happening. But you don't know until you start seeing recovery with support that you can give for all of this possible things that you're correcting for: blood pressure, helping him oxygenate, etc.
Are you sure that he didn't take anything that could have caused this?
No, he's a good kid. He's in college. He has a part-time job. He even chose to live at home so he can focus on school.
Dr. Robbie, from the urine.
What's that?
It's a drug test, and it is positive for fentanyl.
Oh, if he took fentanyl and they gave Narcan, I'm surprised there was no reversal.
No, not our son.
Well, maybe he didn't know that he took something with fentanyl. I don't know. The hows and the whys don't really matter. What matters is spending time with Nick. We've got some more tests to run. We'll know our options after that. But in the meantime, why don't you take a seat, talk to him?
The problem with fentanyl and why it causes overdoses so rapidly and so aggressively, this is a medication that's dosed in micrograms as opposed to milligrams. That shows you the potency of the medication and how easy it is when there's some of it present in not validated amounts, how easy it is to overdo it. And if you think about drug dealers who are selling drugs and they're trying to make them more addictive, if you put opioid medications like fentanyl, a tiny amount, you could make that medication more addictive, making the people want to buy more. But the problem is, if you mess up that dosage even slightly, again, these are micrograms, I'm talking about tiny, tiny, minuscule amounts, you can kill someone. So unfortunately, that's how these situations oftentimes play out.
Can we move Nick Bradley to a private room?
Like you're gonna make it? Didn't you respond to Narcan?
I think his pinpoint pupils just grew into balloon pupils from brainstem death.
Shit. Mr. Spencer's room. What is happening?
His oxygen levels are dropping. Mr. Spencer, how are you feeling?
I don't remember where I parked.
Mr. Spencer, do you know where you are?
So remember, he has baseline dementia, and on top of it, he has sepsis, which makes it already a higher chance of developing altered mental status, even if he was perfectly healthy to begin with.
It's so loud in here.
Dad, do you know where you are?
Dad, look at me. What's my name?
I don't know.
Muting the alarm is a good first step here because sometimes the alarm makes families panic. In fact, if I have a patient on a do not resuscitate order or comfort care orders, I already have the alarms pre-muted to make sure that we're not scaring the families because they already have a plan in place. There's no need to alarm us if the plan starts actually happening.
IPAP 15/5. Step out. So
this is where he's having air hunger, shortness of breath. Usually in a situation like this, if we're focusing on his comfort, we recommend the dosing of morphine in order to decrease that air hunger to allow him to feel more comfortable. Because one of the effects of morphine is not just pain relief, but a decrease in that sensation of feeling like you have a lack of air, which makes people feel comfortable.
What's BiPAP?
BiPAP is a breathing machine that you put over the mouth that provides a little bit of breathing support, more so than a traditional mask, because it provides extra pressure.
It is a pressurized air mask that can improve his oxygen. Either his pneumonia is getting worse or his heart couldn't handle the fluids that we gave him to treat the sepsis. His lungs are filling up with fluid.
Can't you take the fluid away?
Not without his blood pressure crashing with.
So that's always this fluid balance is at odds when you have an elderly patient with a slightly weaker heart, because think about it this way. Blood pressure drops because the patient has an infection. In order to raise that blood pressure, we can do one of two things. We can give them a massive amount of fluid, or we can put them on artificial pressors. Artificial pressors are like, think about adrenaline. So usually we start with fluid, and if we give that fluid, we start increasing the amount of demand that's being placed on the heart because we're increasing the pressure and we're increasing the fluid load onto the heart. If the heart starts struggling with that extra amount of fluid, what ends up happening is that fluid ends up building up and backing up into the lungs. And we start also seeing it like on their ankles as well. So again, backing up. Patient has infection. To treat the infection, we need to raise the blood pressure so they don't die. We give fluid, they become fluid overloaded. Fluid goes into the lungs, makes the problem even worse. Don't give enough fluid or give them medicine to get rid of the fluid, which is called Lasix, the generic being furosemide. They can pee out that fluid, which is a good thing, but then again, we're lowering their blood pressure. They're not supplying enough circulation to their brain and vital organs. So there's no good place to go here.
Let's just hope the BiPAP works.
And if it doesn't?
BiPAP also creates that pressure, which can help get rid of some of the fluid from the lungs.
Then I would need to know your decision about using a breathing machine.
We're still talking about it.
Well, we know he expressed his wishes in writing. Do not intubate.
We're thinking try it for a week.
That would be a very painful week.
Every time a patient is intubated, not only are there monitors, there's blood draws every morning. So imagine he's getting poked every single morning because we want to make sure that the intubation settings are correct, that the patient is improving. Patient's not going to be getting a lot of rest. It's literally, you're getting all the risks and harms of all the treatments with almost no benefit. Because what's the benefit? Even if he comes out of it, he's going to be at a worse baseline than he was before, and he wasn't doing great before to start with. I'm saying this kind of to paint the most honest picture of it.
He wouldn't get a lot of rest with all the monitors and all the blood tests. He might need to be sedated. He might need to be restrained because he'd be in an unfamiliar place with a very uncomfortable tube down his throat. And he wouldn't really know what was happening. Elderly patients can often develop psychosis.
But he might get better.
Or he might get worse.
The thing that I like to say in those situations is he might get better from that situation, but for him to return to baseline of where he came in, which was already not great, is near impossible or very, very low.
What would you do?
I really can't answer that for you. This is your father. That's your decision to make.
I would just say, what would he want to be done? And he expressed it, so I feel like that's the answer.
I can guarantee you that we will keep him as comfortable as possible if a natural death is what you choose.
But he's not your father.
Very difficult discussion. He's doing a great job handling it.
Drug-seeking woman kicked off a city bus for disrupting and disturbing passengers. She's been screaming for narcotics nonstop. We found an empty Percocet bottle.
What the hell are you doing?
Ago.
It's really wild to say someone's drug seeking just because they found a Percocet bottle and someone's screaming for pain medicine. You probably should ask what medical condition they have. I mean, at the least.
Why can't you call it? He's been uncooperative and combative since we picked him.
Let her go.
My meds at home aren't working. Please, I have sickle cell.
I was gonna say, she looks like she's in sickle cell crisis. Sickle cell crisis is one of the most painful things ever, and a lot of times it gets labeled as drug-seeking behavior, but sickle cell crisis is incredibly painful. Bone pain is terrible. Remember, sickle cells can create anemia where the cell itself is not a normal shape, and as a result, it causes an occlusive crisis where the blood basically starts bunching up upon itself, leading to immense pain.
Joyce, is this your sickle cell pain?
Yes.
10 milligrams of IV morphine.
You really want 10?
Yes, repeated in 5 minutes if needed. And she needs a dilaudid drip. This is a vaso-occlusive crisis. I'm so sorry this happened. It's gonna be okay now.
Live wire hit his left forearm. Shocked him once for VFib.
Was there a power pole down?
No, abandoned factory. We found bolt cutters at his side. Got electrocuted.
Try to steal copper?
Most likely. Power line fried his arm, and the current through his whole body stopped his heart.
Major burns will happen from electrical activity like that. Remember, when you shoot electric current through your body, you can disrupt the heart's natural rhythm, leading him to be in this very dangerous cardiac rhythm, which generally can be fixed with advanced cardiac life support. And I think that's what they gave him. I'm curious about his vitals at the moment. For severe burns, you need massive amounts of fluids.
Steady, lift. Add myoglobin and a CK to the labs.
To see if there's damage to muscle tissue.
2 liters normal saline, wide open.
Wide open, meaning just maximally give as much fluid as you can into those 18 gauge IVs that should be in both arms.
Dr. Santos, what are we worried about?
Rhabdomyolysis.
Rhabdomyolysis is when your muscles get severe damage. Can happen as a result of extreme exercise, can happen as a result of electrocution.
From tissue damage can kill the kidneys. Ongoing risk of cardiac irritability.
Excellent.
AP pads in place. Tense ventral compartment.
When there's a tense compartment, that could lead to something known as compartment syndrome, where pressure builds up inside a limb, and as a result, you start killing off the end portion of the limb. And the only treatment for it is a fasciotomy, where you actually cut to expose the fascia and allow the pressure to escape. So you're basically cutting to allow the patient to do better.
Anterior compartment pressure is 49.
Burn caused massive swelling.
With a burn, you get not just massive swelling, but sometimes you get skin contractures, where when the skin contracts and you have swelling, it basically creates a tourniquet on top of the arm.
What does he need, Dr. Santos?
Fasciotomy.
But he still has a radial pulse.
So when you're doing that fasciotomy, you want to be very careful. There's significant nerves that lead down into the hand because the hand has really good sensation, pinpoint discriminatory sensation, and obviously for the major blood vessels as well.
This is the path to avoid the median nerve and all major vessels.
Maybe just watch the first time.
Watch one, do one, teach one.
She'll hold the blade, I'll cut. Template of Dr. Santos. We'll start proximal. How much pressure? Just about this much.
Yeah, ideally I would have liked to see her witness one before starting to be even involved in the process. They are at a good depth though.
Through the skin and sub-Q.
The biggest part of why that is a little safer than you would imagine, meaning both of them are working on it, because it's really about the amount of pressure that you're applying and the depth and the location. And since she mapped it out and was controlling the depth, safer than perhaps a traditional surgery.
Hi, I heard you wanted to talk to me.
Yeah, that alarm kept going off.
Yeah, why don't we step outside? The alarm is for low oxygen.
He's in a position where you have to intubate if you actually want to do something. It's probably not the right choice.
Does he need more of that BiPAP?
I'm afraid that's as high as we go. So the decision at this point,
We want you to put our father on the breathing machine.
even though that goes against his desires to not be intubated,
We're not ready to let go yet.
you're absolutely certain you want to put your father through this after everything I've told you? I may have to honor his advance directive.
I'm actually surprised that he's taking into consideration their thought when he already has an advance directive on file. I've never had a situation where family overruled an advance directive that a patient put on. A patient at any moment could change their advance directive. That's true. So like they may be DNR, but then when they become hungry for air, they may say, intubate me, save my life, do whatever, and you have to honor that. I don't know how it works exactly with a healthcare proxy or durable power of attorney.
If not, we can talk to your hospital attorney.
Okay, you can sit with him until we're ready.
And when will that be?
Momentarily.
You okay?
Yeah, for sure. I just hate seeing families torn apart.
You sure you okay?
100%. I'm just gonna get some air. I am savage, classy, bougie, ratchet, sassy, moody, nasty.
What a pump up song. Oh no, they're gonna throw out of the van a gunshot victim.
I need help. I got stuck.
I knew it. This literally happened to me, and I had to plug it right then and there.
Alice.
Oh my God, this is literally, I'm getting full on flashbacks, except mine was ephemeral. It's in a bad area where you're gonna have to do something called an X-lap, which is an exploratory laparotomy. When you're gonna do a technique called running the bowel, where you're literally gonna do this to see if the bowel's damaged, because it's near impossible to know what the bullet impacted from just seeing where the bullet hole entry and exit is.
Systolic's only 80, 14 gauge, left AC.
Systolic being 80 is a really bad sign. That means a lot of blood loss is happening, probably into that retroperitoneum area that I talked about earlier.
We got 2 units of whole blood going on the rapid diffuser.
Call the OR, we'll be right up.
Lungs up.
Morrison's of full blood. See that?
Yeah. Tore up his liver.
Oh, and it hit the liver. That's a lot of bleeding. In situations like this, something that most people don't think about that could happen is retribution stuff. So sometimes this person went to go kill someone and they ended up getting shot, and then a gang member will come back into the hospital because that person shot their friend, and it becomes really a dangerous situation. And most people don't think about that, but hospitals are a place of revenge. So you gotta be really careful and thoughtful with security on that.
How's she doing?
Still breathing after 20 of morphine.
The reason why they're making such a big deal is because those are big doses of morphine, and some people that can cause respiratory distress. But that is in opioid naive patients, meaning those who have not received large amount of opioids in the past. Those who have gotten opioids quite often, people who have sickle cell crisis often, who have chronic pain, they become more tolerant, so they can handle higher doses, and in fact need higher doses in order to actually get the outcome from the medicine.
How's the pain, Joyce?
Oh, a little better.
We've ordered an exchange transfusion.
Figured I needed that.
What's your normal regimen at home?
90 of extended release morphine every 12 hours and oxycodone for breakthrough pain, but it wasn't working.
Starting IV Dilaudid at 4 an hour.
Dilaudid, the medicine they're talking about, is approximately 7 times more powerful than morphine per dose. 7 milligrams of morphine is approximately 1 milligram of Dilaudid.
How do you know she's not drug
You
seeking?
can't fake a hemoglobin of 6. Do you know what sickle cell crisis does to the body? Blood cells get caught and plug up your capillaries and deprive all your cells of oxygen. It's been described as an electrical stabbing pain that feels like it's breaking your bones and flushing glass through your body.
I never thought of it like that.
Little empathy goes a long way with those suffering in real pain.
Yeah.
Don't worry, you'll get good at spotting the fakers, and half the time all those people need is someone to really listen to them and hear their story.
Great feedback. Good teaching moment. I just probably would have done it not in the middle of a hallway, just so it's a little less awkward, but otherwise great.
What?
I gotta go tell those parents their 18-year-old son is brain dead.
What are you gonna say?
I'm going to say that it's likely, but we still need to do an apnea test and a cerebral perfusion study.
What are we praying for miracles today?
They need time to process before they can accept what's happening.
You ever consider taking that advice? Physician, heal thyself.
Don't you have patience?
Doctors are the worst patients.
No. People wake up from comas. You can wake them up. You can do that. You can talk. You can talk as that.
Just being silent and present in the room is a really good move here. Raw milk is going viral in more ways than one. Click here to check that out, and as always, stay happy and healthy.